How do we separate these conditions from Parkinson's disease or vascular Parkinsonism? That's our job, and it's often very difficult, and sometimes patients will leave the room with a list of 3 different things that they might have. But I've told you the pure akinesia with gait freezing will have rapid hyperphonia, fast speech that's soft, and fast micrographia. They write in very small letters but quickly. In Parkinson's disease, they write in small letters but slowly, and it tends to tail off and break up. Parkinson's disease obviously has tremor in response to medications, and vascular Parkinsonism we'd find signs on the scan of previous strokes. And again, normal sense of smell in pure akinesia with gait freezing. So back to the car shed and the electricians in the car. That protein I showed you under the microscope before is a normal protein. Everyone's got it throughout the brain and in the muscles. However, in tau, for some reason, it accumulates and causes protein clumps. Now, we don't know if that causes the disease or is the result of the disease, but what we do know is it characterises the disease. So it happens in PSP, not in Parkinson's disease. It's got a genetic basis. That doesn't mean it's inherited. It means that about 70% of us have a certain type of genetics for this tau protein. It means 30% don't, and those 30% are less likely to get PSP. So obviously 70% of the community do not get PSP, but it's those 30% who don't have this typical genetic background are relatively saved from getting PSP. That doesn't mean if we have someone in front of us and we say, oh, let's have a look at their genetics and see whether or not they really have PSP or Parkinson's. It doesn't work that way, but we know from our understanding of the protein in the brain that it's a modifier, so it's a genetic modifier rather than an actual risk factor or a cause. This is important for our understanding of what causes the disease. And if we look, again, this is from some of our work in the brain bank, if we look at the different brain areas that are involved in PSP, the patients whose post-mortem examination would show mainly the basal ganglia being involved with the tau pathology are much more likely to have PSP Parkinsonism or the pure akinesia version compared to if a lot of the cortex is involved with the pathology. These patients will only have Richardson syndrome. So we're understanding a little bit about where the protein spreads around the brain and what sort of symptoms it causes, and this should give us some sort of insight into what differentiates someone who has this type of PSP compared to that type of PSP. My view is that there's probably other genetic modifiers that make the outlook better for these guys and worse for these guys, and we'll find that out over the coming years. Are there any diagnostic tests for PSP? The answer is no. We can look at cardiac imaging. This looks at the nerves around the heart. This is a patient who has MSA and a normal scan. So this is a normal scan. The heart takes up this tracer, but in Parkinson's disease, the heart does not take up the tracer. That's because of loss of nerves around the heart. Doesn't usually translate to heart problems, but it's just a sign that we've recognised. And patients with PSP would be expected to have a normal scan there too. So this can be somewhat useful in separating patients with Parkinson's disease from PSP, but not accurate enough to use on everyone. Looking at the sense of smell, I've told you that might be able to separate patients. Well, if you compare this group of 37 patients with Parkinson's disease whose average age was 62, they were in about, on average, they scored about the 10th percentile for smell discrimination. This is in a 40-item scratch and sniff test. Patients with PSP, and we had 12 patients, they scored on average 18th percentile, so well into the normal range. And so this, in group data, can separate the two conditions quite well, but on any one patient, there might be a bit of variability, so not really good at separating the two conditions. What about looking at other biomarkers? There's a lumbar puncture test that has been shown in Italy to separate out PSP, and in this excerpt from their paper, you can see this line here, which the lab guys will do on the fourth floor over there. is lower in the patients that had PSP compared to Alzheimer's and Parkinson's and dementia with Lewy bodies. Problem is the pathology is very similar between PSP and cortico-basal degeneration, so those two should be the same. That's a criticism of the technology in the paper, but what it means is it's very difficult to develop, even if you put lots and lots of work into it, it's very difficult to develop in vivo, so during life, tests that discriminate between PSP and Parkinson's and other conditions. So what are the treatment options? I'm not going to talk about the therapies because you guys are expert on that. I always try levodopa, which is the Parkinson's medications, I always try levodopa if Parkinsonism is present. So if patients have rigidity and bradykinesia, I always try levodopa. Often there's not a response, or usually there's not a response. Sometimes when you stop the medications, people feel worse. So you'll see a lot of people with PSP on a small dose of Parkinson's medications just because they felt a bit worse when they're off it, but you can't really tell much in the way of difference. Amantadine was developed in the 1950s by the US Army excuse me, to reduce the risk of flu. It was found in the 1960s when it was given to patients with Parkinson's disease that their Parkinson's symptoms improved a little bit. And occasionally we find that gate freezing in PSP can improve a little bit if we use that medication. The result, unfortunately, is usually disappointing. Amitriptyline is a tricyclic antidepressant, probably the most prescribed medication in all of neurology. We use it for migraine, we use it for pain, we use it for depression, we use it for hypersalivation and urinary problems. I've found probably about 1 in 5 patients with PSP will find an improvement in their speech by louder speech and improvement in their swallow once they're on this medication. It's certainly worth trying if those problems are issues. We use botulinum toxin for the tendency for the eyes to close over, so that's blepharospasm, injecting around the eyes, and also in the neck if that extension rigidity is really uncomfortable. And Stilnox is helpful in the odd patient. There's a few case reports where someone's got out of their chair for the first 2 years once they've been on the right dose of Stilnox. I've never had that experience. I have seen the videos, so I do believe it happens. Deep brain stimulation surgery, which we use for drug refractory symptoms in Parkinson's disease, is not a worthwhile option in PSP. That's been shown several times. So you've all heard about the Carer's Manual, which is a very important part of the management of patients with PSP. There are a few emerging drug trials now that we're at the point in the 21st century where we know something about the protein that causes it, something about the natural history, something about the parts of the brain that are affected, and a way to measure the severity of PSP. We're now at the stage of trying some things that might adjust how that tau protein accumulates in the cells and is associated with nerve cell death. Lithium is one of the most simple and oldest drugs developed here in Parkville and being used in bipolar affective disorder and depression for half a century now. This medication, or lithium itself, stops an enzyme which tends to bunch together tau. And there is a multi-centre study in the Northern Hemisphere looking at the impact lithium might have on the natural history of PSP by trying to stop that tau bunching together. Planning to study 30 patients in each group, so placebo versus control. Unfortunately, the study has been very slow to recruit patients, partly because everyone has to have a lumbar puncture at study entry and people don't like lumbar punctures. They've had difficulties with lithium toxicity. I don't believe lithium's the answer. I have one patient who'd been on lithium for 15 years and still developed PSP, and another patient who was started on lithium because of the rumour of this study emerging a couple of years ago, and he died from lithium toxicity during a heat wave in London.